Good morning, my dears. Today we are going to discuss acute diarrheal diseases. This acute diarrheal diseases is not only important for theory, that even can be kept as a clinico-social case discussion. So in this topic, you should be knowing how to demonstrate the signs of dehydration. What are the signs that can be expected in a child when presenting with diarrhea? And you should be able to categorize the management plan of management in a child presenting with dehydration, different grades of dehydration. So this is with respect to clinico-social case. When it is asked as a theory question, you'll have to go with the causes, presentation, and the investigation and the treatment. The acute diarrheal diseases. Diarrhea is defined as passage of more than 3 times, that is passage of stools more than 3 times over a period of 24 hours. When the person passes more than 3 times, but it is of solid consistency, that cannot be considered as diarrhea. The important criteria for diarrhea is the consistency. So definitely, it should not include solid consistency. It should be altered. Either it can be liquid, it can be watery, or semi-solid. So that criteria is important to make a diagnosis of diarrhea, that is altered consistency. The watery diarrhea is passage of 3 or more liquid or watery stools in 24 hours. Dysentery, presence of blood and mucus in stools. Persistent diarrhea is diarrhea lasting for a period of more than 14 days. So according to the presentation of diarrhea, can be classified into watery diarrhea, dysentery, and persistent diarrhea. Watery diarrhea, the reasons can be rotavirus diarrhea, E. coli, cholera, dysentery, shigellosis, amoebiasis, and persistent diarrhea can be because of systemic disorders, not with respect to infection to GIT. It can be because of any other system disorders like hyperthyroidism, diabetes mellitus, pancreatic insufficiency, irritable bowel syndrome, inflammatory bowel disease. So there can be other causes of diarrhea. The common bacterial causes of diarrhea, the bacterial pathogens that are responsible for presenting as diarrhea are Vibrio cholera, Shigella, E. coli, Salmonella, Campylobacter jejuni, Yersinia enterocolitica, Staphylococcus, Vibrio parahemolyticus, Clostridium difficile. The viral pathogens causing diarrhea are rotavirus, adenovirus, calicivirus, astrovirus, Novak agents, and Novak-like viruses. So when you come to Vibrio cholera, that is one of the important epidemics that can occur in any part of the country due to contaminated water consumption. And the fluid loss is which will be out of proportion, which you cannot imagine. The child or the person can go for vomiting and diarrhea at a time, going for massive fluid loss from the body, even causing death. Shigella, it is a passage of mucus and blood in stool accompanied with tenesmus. And Escherichia coli, you have different strains like enterotoxigenic E. coli, enteropathogenic E. coli, enteroinvasive E. coli, creating different forms of diarrhea. So these are the other bacterial pathogens. Then coming to parasitic causes of diarrhea, Entamoeba histolytica. Even this can be, the diarrhea need not be watery. It can be semi-solid, bulky, and may or may not be mixed with blood. Giardia lamblia, Cryptosporidium parvum, Isospora belli. Cryptosporidia parvum, Isospora belli, common in immunodeficiency children and HIV. And coming to other causes of diarrhea, that is non-infectious causes of diarrhea, hyperthyroidism, where the metabolism is high. Every system goes for hyperfunctioning, like heart goes for increased performance, that is palpitation, and GI goes for hyperperistalsis, very active, hyperactive GIT going for diarrhea, and many other presentations. So diarrhea is one of the important clinical symptom of hyperthyroidism. Then diabetes mellitus need not present only with polyuria, it can sometimes present with diarrhea, pancreatic insufficiency, and food allergy can cause diarrhea, lactose intolerance. Antibiotic induced diarrhea, that is also one another important cause of diarrhea. So some beta blockers and antibiotics like penicillin group of drugs, vancomycin can cause diarrhea. Then irritable bowel syndrome, inflammatory bowel syndrome are some other causes of diarrhea, non-infectious causes of diarrhea. Now coming to the infectious causes of diarrhea, the epidemiological triad is the agent factor, host factor, and the environmental factor. Agent factor, we learned enough about the agent factors, that is the bacterial pathogens, viral pathogens, parasites, and protozoal agents. And coming to the host factors, age itself is an important risk factor for diarrhea. The children between 1 month to 2 years are more prone for diarrhea than when they grow up, because that is the age they tend to lick or they tend to keep the things into their mouth without knowing what is what. So this leads to fecal-oral route of transmission. And then children with or patients, people with immunodeficiency disorder, with low immunity to fight against a pathogen can present with persistent diarrhea or a severe form of diarrheal presentation. Or when the person has got malnutrition, when the nutrition is poor, immunities will be poor, and hence diarrheal episodes are very often and severe also. And coming to the environmental factors, when the sanitation is poor and the person is not maintaining personal hygiene, definitely we are going to invite diarrhea. Poverty, overcrowding, all these invites diarrhea. Then coming to transmission, most of the diarrheal agents are transmitted by fecal-oral route, because the feces is overwhelming with E. coli and other gram-negative bacilli. When this is not managed properly, like proper sanitation, this tends to get contaminated with water or the other items, then we tend to have an infection, that is fecal-oral transmission. So once when the sanitation is made proper and when hand hygiene is practiced properly, this fecal-oral route of transmission can be broken. Some viruses, sometimes it can be even transmitted through air. And nosocomial transmission is also possible. Shigella is mainly transmitted from person to person. Then, does season favor diarrhea? Yeah. Cholera is very common in winter. Rotavirus diarrhea, again, common in winter. Shigellosis in summer. And then the person at risk, that is the host factors. Cholera, very common among children who are 2 years and above, and uncommon in very young infants. Whereas rotavirus is very common in infants, children less than 2 years. Shigellosis is more common in young children aged below 5 years. Rotavirus diarrhea, very common in children aged 1 to 2 years. E. coli diarrhea can occur at any age. Amoebiasis, very common among adults. We have among the bacterial pathogens, we have strains like Vibrio parahemolyticus, Vibrio cholera, Shigella flexneri, Shigella sonis, Shigella boydii, Shigella shiga. So these are other strains which can cause diarrhea. So in the Escherichia coli itself, we have different strains like enterotoxigenic E. coli, enteroinvasive E. coli, enteropathogenic E. coli, enterohemorrhagic E. coli, enteroaggregative E. coli, and diffuse adherent E. coli. So all can present with diarrhea, but the thing is, invasive means a lot of tissue invasion and blood and mucus mixed diarrhea. Enterohemorrhagic, again the term itself, they tend to bleed. The GI tend to bleed and blood loss is more. Enterotoxigenic, more of secretion. The enteropathogenic, more of secretory type of diarrhea. So let us know about the individual pathogen. So cholera, very commonly we say it is rice watery stool, as though when we wash that rice before cooking, we get that dull white color fluid. The stool of cholera will mimic rice water. And there will be a lot of fluid loss through vomiting as well as diarrhea, hence marked dehydration. The person can go for dehydration, severe dehydration within a couple of days. And they can present with projectile vomiting, but they don't present with fever or abdominal pain, effortless diarrhea. Then muscle cramps, hypovolemic shock, and scanty urine. Of course, kidney sacrifices its blood supply, and hence they can go for oliguria, anuria, renal failure. Then E. coli, watery stools, vomiting is common. Dehydration can range from moderate to severe, and fever can be of often moderate grade, accompanied with abdominal pain. Rotavirus diarrhea, insidious in onset. Prodromal symptoms can be fever, cough, and vomiting preceding diarrhea. The stools are watery, semi-solid. The color is greenish or yellow. Typically, it looks like yogurt mixed in water and sticking to the pan. Mild to moderate dehydration. Fever can be of moderate grade. In shigellosis, the characteristic feature for shigellosis is tenesmus. That is pain around anus during defecation. The child will avoid to pass stool. But when it passes, it will be very painful and cries while passing defecation. So they get exhausted because of that painful defecation. So frequent passage of scanty amount of stools, mostly mixed with blood and mucus, and they get tired because of that pain. Moderate to high grade of fever, usually they will not present with dehydration, they present with exhaustion and pain. The clinical features of amoebiasis, it presents as offensive bulky stools containing mucus and sometimes blood, lower abdominal cramp, mild grade fever with no dehydration, because not much of fluid loss, so no dehydration. Laboratory diagnosis, we can go for stool microscopy to identify the parasite or protozoa or the eggs, worms in the stools. Then followed by dark field microscopy, specifically to look for the swarming motion of the cholera. And stool cultures, mainly for gram-negative, ELISA for rotavirus, and immunoassays and bioassays or DNA probe tests to identify E. coli strains. Next, we have identified the pathogen. Whether they identify the pathogen or not, once when the patient presents with dehydration, once when the patient presents with diarrhea, we'll have to assess whether they are in dehydration or not. So the next work, what we have to do is we'll have to do a head-to-toe examination. So, and the head-to-toe examination, if the child is less than 2 years or less than 6 months, you can go for searching the anterior fontanelle. How about the contour? So sunken anterior fontanelle is a characteristic sign of dehydration, and followed by eyes. So when the eyes are dry and very dry, we categorize them as some and severe dehydration. And looking into the Oral cavity, the tongue is dry, oral mucosa is dry and very dry. Again, some and severe dehydration. You can look into the abdomen, scaphoid abdomen, and there is a test called skin pinch test. The skin pinch test, usually you take a pinch of the abdomen and release it. So if the skin retracts immediately, then within fraction of second, there is no dehydration. If it takes 1 to 2 seconds to retract, there is some dehydration. If it takes more than 2 seconds to retract, then as like a dough, wheat dough. So then it is very slow retraction. The child is gone for severe dehydration. And we'll have to assess the thirst nature. So no dehydration, the child will be thirsty or may not be thirsty. In some dehydration, the child feels thirsty and drinks water actively, very aggressively. But when there is severe dehydration, the child doesn't have energy to even drink water. So they tend to refuse. So these are the clinical signs with which we assess the dehydration by doing a head-to-toe examination. Again, we'll have to ask the urine output. If the child has not passed urine since the start of the diarrhea or reduced quantity, we'll have to think in terms of renal shutdown. Then we'll have to act immediately, like we'll have to plan for the management. So we have no dehydration, some dehydration, and severe dehydration. Mild will come under no dehydration, some and severe dehydration. So no dehydration appearance is irritable because of passing diarrhea, but the anterior fontanelle, eyes and tongue, skin, breathing, everything are otherwise normal. But when there is some dehydration, whatever I had told, that is the anterior fontanelle sunken. When it is severe, very sunken, dry, very dry, tears, eyes, dry, very dry, and then skin pinch test. It retracts within 1 to 2 seconds, takes more than 2 seconds. So some and severe dehydration, that's how we assess. And in addition to that, we'll have to assess the urine output. The pulse is also an indicator of dehydration. When the child is losing fluid through stools and vomiting, the heart tends to go for contracting more, that is tachycardia, rapid, low volume pulse. And when it is severe, it is feeble and it may not be even perceivable. Then weight loss. Weight loss of no weight loss, 5 to 10% weight loss, more than 10% weight loss. So this is normal or no dehydration, some on severe dehydration respectively. So the treatment goes this way. Rather than going for searching the pathogen and giving antibiotics, then the complication is dehydration. Presentation is dehydration, dehydrated child. When you assess child with some dehydration or with severe dehydration, the immediate plan of management should be rehydration. So how we are going to rehydrate the child? If the child fits under some dehydration, we'll have to go with oral rehydration solution. The child fits into severe dehydration, no point in giving ORS. We'll have to start IV fluids. The best IV fluid is finger lactate solution. When there is some dehydration, we'll have to advise oral rehydration solution. WHO ORS is available, which contains a complex of sodium chloride, sodium citrate, potassium chloride, glucose, and water. So that is an ideal fluid for children presenting with some dehydration. If the same child presents with weight loss of more than 10% and all severe signs of severe dehydration, like very sunken fontanelle, very dry eyes, very dry mouth, and skin pinchability test more than 2 seconds, urine output is compromised, we'll have to go with IV fluid replacement. The best fluid for replacement is ringer lactate solution. Then we'll have to assess whether how much to replace. So if we are planning to give ORS for children with some dehydration, we'll have to give 75 ml per kg body weight in addition to routine fluids and breastfeeding, if at all the child is less than 1 year or 1.5 years. Then if the child is into severe dehydration, we'll have to divide this way. That is 100 ml per kg body weight should be, we'll have to take into account. So suppose if the child is weighing 10 kg, 10 into 100, 1000 ml per kg, 1000 ml should be replaced. If the child is more than 1 year, you will have to replace the fluid, or you will have to infuse the fluid within half an hour. If the child age is in months, you can replace the fluid within half an hour. So you'll have to divide that 1000 ml into 30 and 70%. So 30% is 300 and 70% is 700. This 30% should be replaced within 1 hour in a child less than 1 year, and within half an hour in a child more than 1 year. The rest 700 ml should be replaced within, that is 5 hours and 2.5 hours respectively. So this is the IV fluid replacement for a child having severe dehydration. So this duration will last for 6 hours when the child is less than 1 year. Replacement will last for 3 hours if the child is more than 1 year. And coming to the oral rehydration solution in a child presenting with some or no dehydration, the calculation goes this way: 75 ml per kg body weight should be replaced in addition to the routine water intake, and if at all breastfed child needs routine breast milk intake. Then coming to the antibiotics, if it is bacterial, antibacterial agents, viral, actually we don't have no need of that. It will be self-limiting. Only thing is we'll have to replace if the child is losing fluid at a very fast manner. And protozoal agents, we do have metronidazole and all. The metronidazole, tinidazole, secnidazole. And if it is because of parasite, of course, we do have drugs. That is the one which I mentioned. And if it is worms also, we do have anti-helminthics. Next is the composition of ORS. So this ORS is the golden treatment for children with no or some dehydration. So the composition of ORS is, it contains sodium chloride, trisodium citrate, sodium bicarbonate, potassium chloride, glucose. So this citrate is mainly added to increase the shelf life of the sachet, of the powder. The other things will address to the electrolytes of our body, the important electrolytes of our body, which are lost because of either vomiting or diarrhea. So the composition goes this way: sodium chloride 3.5 grams per liter, trisodium citrate or soda bicarbonate 2.9 or 2.5 grams per liter, potassium chloride 1.5 grams per liter, and glucose 20 grams per liter. Then the specific antimicrobial agents against different pathogens are cholera, tetracycline, doxycycline, ciprofloxacin. Of course, if the child is less than 14 years, we cannot go for any of the options given. We'll have to go with the cephalosporin group of drugs or zithromycin group of drugs. Of course, we can go for ufloxacin. Then shigellosis, the treatment, the specific antimicrobial is nitrofurantoin, nalidixic acid, ciprofloxacin, ceftriaxone. Then amoebiasis, metronidazole, protozoal. The main complications of diarrhea are after losing so much of fluid through electrolytes, through vomiting or diarrhea, the child can go for dehydration. That is the major water loss from the body. So this water loss itself can present as hypovolemic shock and the child can collapse. Electrolyte imbalances, the common electrolyte imbalances are hyponatremia, hypokalemia, and even chlorides can be lost through the effortless vomiting and diarrhea. So the child can go for tetany because sodium, potassium, ATPase, we need these electrolytes for effective functioning of the cell, for the GIT to contract, for the heart to contract. So the muscles can go for spasm, tetany. And convulsions. So hyponatremia, the child can go for convulsions. Then hypoglycemia, not only the child is losing electrolytes or water, it is nothing is absorbed from the GIT, hence the child can go for hypoglycemia. When water is lost through the vomiting and diarrhea, our body is deprived of fluid. So the splanchnic circulation will sacrifice itself and turn their blood to the central circulation. So the first organ to sacrifice its blood supply is skin, then followed by the other organs, so that they divert their blood circulation to brain, heart, lungs for the vital activity to be performed. So these are the important complications which can occur due to watery diarrhea. So in what ways we can prevent? We have seen the diagnostic modalities for diarrhea. Even before diagnosis, we'll have to save the child from dehydration. That is the treatment modalities of diarrhea, mainly rehydration. That is the treatment, first line treatment for diarrhea. So rehydration, we learned about the ORS when child presents with some dehydration, and IV fluid replacement when the child presents with severe dehydration. So all these diagnosis and treatment comes under secondary level of prevention. And if you properly replace the fluid and properly treat the infection with antibiotic, you are preventing the complication. That is failure, electrolyte imbalance, dehydration, hypovolemic shock, mortality. So that is tertiary level of prevention. Then coming to the primordial and primary level of prevention, even before the onset of preventing the episodes of diarrhea, we can go for primordial prevention and primary prevention. So consuming safe water and food, that is itself an important primordial or primary measure level of prevention which one can take in order to avoid the GI infection. Then hand washing technique is an important milestone to break the fecal-oral route of transmission. Proper sanitation, of course. Open air defecation was in practice some 2-3 decades back. It is still in practice. It is there. So still there are villages, there are places where they do practice open air defecation. But this open air defecation should be withdrawn completely, and everybody, government is promoting or sponsoring so much to have their own toilets in order to practice proper sanitation. So this helps in breaking the fecal-oral route of transmission. So that is how we can lead a safe, we can have safe drinking water and food, thereby by practicing proper hand washing and proper sanitation. So far we had seen the acute diarrheal diseases, the causative agents, bacterial, viral, protozoal, parasitic causes, and then followed by different presentations of diarrhea in different infections. So like say cholera, rice water stool, Shigella, scanty stools mixed with blood and mucus, and rotavirus diarrhea, and then amoebiasis, which is offensive, bulky stool, but not presenting with dehydration. So the different spectrum of diarrhea caused by different agents, which is very important to make a diagnosis to identify the pathogen with the history and the nature of stool and the consistency of the stools itself. And then we learned about the different laboratory investigations to proceed on to the diagnosis. And most importantly, rehydration. So the child has to be classified into no dehydration, some dehydration, and severe dehydration. No dehydration treatment is ORS. Some dehydration treatment is ORS. And severe dehydration treatment is IV fluid. So if the infection is because of food poisoning or a continued cycle of infection, definitely antibiotics should be given. So if at all antibiotics, we learned about the specific antibiotics against specific pathogens. And at last, we learned about the primordial level of prevention, primary level of prevention, secondary level of prevention, and tertiary level of prevention. Thank you so much for patient listening. We will meet in a different class with a different topic. Thank you, my dears.